What if I told you about a pharmacist service that demonstrated an improvement in patients' hemoglobin A1C lab values, a reduction in patients' emergency room visits, a reduction in patients' hospitalizations, a reduction in provider burnout score, an improvement in patient satisfaction scores, all while saving the organization approximately $86,000? Ready to sign up? Well, these were some of the outcomes we were able to show when we piloted embedding a clinical pharmacist in a high-volume primary care clinic focusing on diabetes care. The background of our project was in June of 2019, 42% of patients in the regional medical group Wheaton IM practice had a baseline hemoglobin A1C of greater than 7%. The American Diabetes Association lists a goal hemoglobin A1C of less than 7% for most adults. So, for our research project's primary outcome metric, we wanted to measure if a clinical pharmacist in the Wheaton IM practice could reduce 30% of patients with a hemoglobin A1C greater than 7% values by at least 0.5% by the end of fiscal year 2020. For a secondary outcome metric, we were curious to see if our work could decrease a physician's burnout score and improve patient satisfaction. Finally, a process metric for our project was to establish some referral criteria for patients with diabetes to be seen by the pharmacist. The first set of data we wanted to examine was to compare our pharmacist's work with another clinic that is similar to RMG Wheaton IM, but does not have an ambulatory clinical pharmacist, essentially serving as a control group for our project. The clinic we chose was RMG Bloomingdale, which is like RMG Wheaton with respect to the number of providers and patient demographics. This chart in Figure 1 is outlining A1C change with and without a pharmacist on a patient's care team from January 2019 to the end of February 2020. The green bar is the percentage of patients that was managed by our pharmacist, and the purple bar is RMG Bloomingdale's patients. On the left, 56.1% of patients that were followed by our pharmacist experienced an A1C decrease of at least 0.5% versus 47.5% in RMG Bloomingdale. On the right, less than 10% of the pharmacist's patients had an A1C increase of at least 0.5% versus greater than 20% in the RMG Bloomingdale group. The first step for our project was to define what services the clinical pharmacist will be providing. Figure 2 summarizes some of those services, such as managing patients with a new diagnosis of diabetes or uncontrolled blood sugars, an elevated A1C, or those that needed diabetic teaching. For Figure 3, we wanted to look at the pharmacist interventions and see which interventions were the most important and impactful. Here's the list of the pharmacist interventions, totaling 884 interventions. That's approximately 2.6 interventions per patient. The most important and impactful interventions were making sure the patient is on the appropriate drug therapy, being able to obtain their medications, and proper education. To address our process metric, we established some set criteria for patient follow-up based on the degree of pharmacist intervention, and is as listed in Figure 4. Jumping ahead to Figure 6, a secondary outcome of our project was to see if our project had any impact on provider burnout. Studies state that provider burnout is directly related to excessive workload, so we gave the providers at RMG Wheaton IM a list of normal day-to-day tasks and asked them, how often do you perform these tasks prior to the pharmacist's arrival and after the pharmacist's arrival? They used a rating scale from never to always. The purple bar is the average provider score prior to the pharmacist's arrival, and the green bar is the score after the pharmacist's arrival. The survey revealed that there was a workload reduction in all 10 surveyed tasks, some as high as 50%. Listed here are the tasks with the greatest reduction in workload. So, by adding a pharmacist to the RMG Wheaton IM practice, it resulted in a 38.6% overall reduction in average burnout score. One of the physicians commented on their survey that this was the most significant improvement in practice in the 15 years that I have worked at Northwestern Medicine. Figure 5 shows to best summarize our project was to provide a cumulative overview of the main results achieved during the lifetime of the project. 38.6% reduction in provider burnout score, 73.3% of patients decrease in late A1C lab percentage, 95.1% reduction in ED visits, 96.4% average patient satisfaction score, 97.3% reduction in hospitalizations, and $85,965 in cost avoidance to Northwestern Medicine in diabetes-related ED visits and hospitalizations. And finally, 80.5% of pharmacist patients with an A1C greater than 7% experienced a decrease of at least 0.5% in Wheaton IM, which shattered our goal of 30%. Thank you.